So I'd like to welcome everyone. This is 7:02, and we're going to start our Insights World Tour. This is again in Canada. We're going to be talking with a few panelists on a particularly important issue. And as you can, just to remind everyone, the Insights Tour is a series of these limited small group, highly interactive sessions where there will be a short presentation followed by a panel discussion. And those of you who attend are all welcome to join us. I will remind you that we're recording, and so during the presentation period, if you don't mind just staying muted and off video, and thereafter we'll be closing down and opening up the panel so everyone can see each other on the grid, and we'll ask you all then to unmute and show your video so we can have some questions. Reminding you also that this is one of 15 separate events that are occurring. So if you have a moment, do go back to the site, the oeworldtour.com site, at which you'll be able to identify and see a number of other presentations. If you haven't signed up, you may wish to join some of those that are coming up in the next few days. So without further ado, I'd like to introduce our speaker this evening. It's Herman Johal. He's a friend and colleague who's an orthopedic trauma surgeon, assistant professor at McMaster University, and also a part of the surgical scientist program here at McMaster. He will be speaking particularly about the role of cannabis in MSK patient care, and I will let him introduce the rest of the panelists. Herman, thanks again for this evening.
Great, thanks, Mo. I'm just going to get my slides up here. Thank you for the introduction, and it's a pleasure to join you guys tonight for the OE World Tour as we continue on. And today we're going to be reviewing the role of cannabis and MSK pain in patient care. So I'm just going to share that and get that big there. Hopefully that's coming through. Just stop me if anything's not coming through the wire here.
It's all good.
Perfect. So we're lucky enough, Dr. Bandari and myself, to be joined by two other colleagues here, Dr. Harsha Santana and Dr. Sunil Apadi, who are both from McMaster University as well. Dr. Santana is from the Department of Anesthesiology, and he's an associate professor as well as a research chair. And Dr. Apadi is has a background in emergency medicine and works as a clinical professor and has a background in epidemiology as well, with a particular interest in chronic pain. So it should be an interesting discussion tonight. So without further ado, let's jump right in to really discuss some of the reasons why this is an important topic to people treating those with MSK pain. And we really can't have a discussion about this without first discussing some of the issues we've had with pain control and the role orthopedic surgeons particularly have played in the opiate crisis. You know, one of the primary reasons why patients may end up on opiates over a long term is due to pain control and unacceptable wait times as they balloon, and challenges with trying to control the symptoms associated with MSK issues. But about 60% of newly started opioid prescriptions were from an orthopedic surgeon, and that was over a third of the high and medium dose starts overall, and over 12% of the starts written by surgeons were for a period beyond 7 days. And considering all of that, it's no surprise that 1 in 5 chronic opiate users obtained their initial prescription from an orthopedic surgeon with associated downstream hospital consequences. What's happened since that's even more relevant is during the pandemic. And as the pandemic continued to worsen, we saw a subsequent impact on the opiate crisis ballooning. And part of the reasons, and there's many reasons why this might be the case, but one of the reasons is wait times are getting worse. And a recent Ontario study showed that each day at the worst part of the first wave, an average increase of 11,000 plus surgeries were added to our backlog. We did a review with Ortho Evidence as well and projected some numbers. And it was no surprise that, you know, given the multiple factors that are in play, wait times may grow to increase about 7 times the pre-COVID numbers. What are the impacts of that? Well, as patients are waiting on these wait lists, they're going to have worsening function, issues with being able to work, other issues with mental health, and also potentially the opiate crisis that we're currently seeing. It's not going to be any surprise if that's getting worse. Now, what's relevant in cannabis? Now, in Canada, as of 2018, cannabis has actually been fully legal from a medical as well as a recreational standpoint. We joined a growing number of countries, those not in red, that were increasingly recognizing cannabis as a medicinal as well as a recreational item that was better left legalized. And as Canada continued to have an environment where cannabis was legal, what we saw around the pandemic is increased in use of cannabis, both for recreational and medicinal purposes. And potentially that could be a result of patients trying to being left on wait lists for a prolonged period of time, but there are also many other reasons why that could be the case. What role could cannabis potentially play from a medicinal standpoint? Well, as a medicine, it's been used and described in use for centuries and centuries. And it's only been the short period of time, and hopefully you can see my mouse here, the short period of time in and around the last 100 years where cannabis has really been identified as something that needs to be controlled. But for eons almost, it seems as if cannabis has been used in multiple different fashions for multiple reasons. Analgesia and pain control, analgesia and other relaxing properties being one of them. Why is this? Why is this potential? Why does this medication? Why does this have potential for medicational impacts? Well, overall, the endocannabinoid system has multiple receptors that are associated with central and peripheral nervous system pain receptors, as well as cells related to bone and muscle function. There's a variety of receptors, but one of the issues is with multiple receptors, there's multiple effects, and that's not necessarily the hallmark of a well-targeted drug that we're looking for. The primary cannabinoids that get most of the press are the THC, or tetrahydrocannabinol, that is psychoactive, as well as cannabidiol, or CBD, which primarily gets the attention for being more therapeutic. There's lots of other cannabinoids though, and those all have been described as having multiple effects, both wanted and unwanted. But people have tried to extend those to therapeutic realms. And overall, quality evidence is still coming out, and in some areas is non-existent, and much of it is hearsay. The real issue is, as we try to look at pain medications and what we can use for pain control, is we really have a tale of two plants. It started out with a poppy and cannabis, and over years, those have both been vilified for various reasons. But we've seen an evolution of opiate-based medications, opiate-based substances used as medications, and potentially one day we might see the same from a cannabis standpoint. We looked at it relative to orthopedic patients, and with respect to chronic non-cancer pain, we have a couple of reviews out there. And overall, we found, looking at just randomized controlled trial evidence, that 36 trials exist with around 4,000 patients looking at cannabis for various therapeutic MSK indications. And looking at various routes of administration, we found that overall, there did appear to be an effect of improved pain control and analgesic effect, or improved pain control for cannabis relative to controlled substances. And primarily, we found that those that were oral administrations had a higher, a more clearly defined impact relative to those that were smoked. Overall, we found that there was moderate quality evidence to support short-term efficacy of cannabinoids for treating chronic non-cancer related pain. The route of administration tended to seem to be in the favor of oral substances, as opposed to those that were inhaled or smoked for chronic pain. There was no increased incidence of serious adverse effects associated with cannabis or cannabinoid substances compared to placebos. And there was an increased incidence of non-serious adverse effects, but those aren't all that different from those that are associated with lots of other substances that patients choose to ingest. When we look at acute pain, we found fewer RCTs and only 12 trials with about 800 patients overall that looked at the question of cannabis for acute pain control. In terms of the substances, most of the studies looked at oral preparations, and we found that overall there was a small but statistically significant treatment effect for cannabinoids over placebo. And for route of administration, we found that those that were intramuscular, inhaled, or topical had a stronger effect. We looked at a survey of our own patients as they came through fracture clinics and MSK clinics in Hamilton. We looked at patients after fracture fixation, as well as those on wait lists for osteoarthritis, with osteoarthritis as well as back pain. And overall, we recruited a total of 12,000 patients to look at their overall perceptions and how cannabis could have a role in their pain control. Most of the patients we had were related, had sequelae of trauma or fractures, but there was also a pretty substantial portion of patients that had joint pain and arthritis. Overall, we found that the majority, and it's no surprise really, that the majority of these patients came in on an opiate already, which is pretty much the standard of care when you think of patients coming through emergency departments after fractures, or patients who've been on long-standing pain medications for arthritis. We've seen in lots of other studies that these patients tend to gravitate or graduate to opiates as their primary pain control. Overall, when we asked our patients about cannabis, though, we found that half of the patients had used cannabis recreationally, and about a third of them specifically used it to control the pain related to their MSK issue. In terms of how they used it, we found that most of the patients preferred in the past had smoked it, but had preferred in the future to use an oral preparation, such as a tablets or other edibles, or liquid or oral mucosal spray. And there's plenty of concern around the harms that could be associated with this, though. So especially in those patients who aren't as open to pursuing cannabis as an option, they were worried about the associated harms, such as impact on neurologic function, addiction, and as well as perception as well as potentially impact on their employment and ability to do higher level functions. So overall, there was a lot of there were many patients who were open to it, but also lots of patients who had concerns. And so that's where I'd like to turn it over to our panel for discussion and see and take your questions on this interesting topic as we move forward here.
Great, that's wonderful. So if we'll get those of you who couldn't, specifically, if I might just start with our panelists, Herman. So maybe either Harsh or Sunil, maybe I'll start with you, Sunil. When you reflect on this information, this data on cannabis, is there reason to believe that we're missing a real opportunity, or is it really too early to know?
So I will speak I'll speak from the point of view of doing community pain work with adults with non-chronic pain first. I would say in 2015, 2016, I was cautiously optimistic. I was guardedly optimistic about the new role of medical cannabis and what have you. In 2020, I would say I'm more of a true believer. Many of our patients have gone down the road, especially with the advent of the CDC opioid guideline changes in 2016 and then Canada's changes in 2017. I will tell you that in a chronic pain population that has a substantial proportion of opioids, that was a very scary proposition for patients who were concerned about having their opioids taken down without an alternative to offer. And the cannabinoids created a space to potentially sidetrack them or shunt them into another treatment strategy. I'm not saying it's a universal panacea at all. It was offered. We usually, for practical reasons of coverage, for example, in my patient population, most of them are on public coverage programs. So there was one prescription oral cannabinoid called Nabilone in Ontario that is covered in one formulation. There's 3 different strengths, but the one was covered. And some of our patients tolerated it and it helped them. Others did not. And then others, the ones who did not and wanted to move into true, if I could call it the real cannabis products. So plants at the time, then oils probably around 2017, 2018, and edibles now have made a difference. And we did a survey population as well with our community pain patients, and we found that there was some reduction in opioid use, and I'm not going to go out there and say that is a substitute for opioids. It's a option. It's an alternative. There are pros and cons. There are safety concerns, but with opioids being pulled back and no new anti-inflammatories, no new neuropathic agents, muscle relaxants or whatever, right? There hasn't been a new molecule, to my knowledge, in the last decade that really was going to be there to revolutionize or change oral pain medication care until the cannabinoids came along. And there has been I think there's a signal there. I may be going on too long, but there's a lot of noise, but there's a signal. And I'm really curious to hear Harsh's opinion and other people's experiences with this.
That's great, Sunil. Harsha, do you have any thoughts on this?
Yeah, as a chronic pain physician, I think everything we have is limited in front of us. So I would like to put everything that can work on the table for discussion. I think there I would find cannabis as an opportunity. But I wouldn't argue for a case of, okay, because the opioids are being taken up, now shall we, kind of substitute it with cannabis? I think that is where I don't find that as equipoised. And I feel like maybe that's still too early to say if we can go that way, just because looking purely from the potency perspective, they just don't match up opioids. But from an argument point of view, whether we should be offering it to patients for chronic pain, yes, for sure, because nothing works for chronic pain. Whatever works, hang on to it. Like very few, I mean, even needles, for example, we do it to so many patients, not everyone gets better.
Just on along the same lines, thinking about it as an opiate, just not an opiate substitute, but something else to be in the armamentarium of how to deal with these patients who are coming in. Oftentimes, when we see it in our fracture patients, these patients have gone through a life-changing traumatic event where all of a sudden the next at least 6 months to a year of their life is going to be very different. For a lot of these patients, that's a psychological adjustment they have to make, and their expectations of their function have to be readjusted, and potentially we see an impact on our patients realigning their psychologic, essentially reframing their injury and what their function is going to be like. So instead of a pain medication, it's just a perception that might be impacted, and just to kind of throw that out there for discussion.
Well, the one thing I will say is that when you look at trauma patients, injured, post, they've had a fracture, they've otherwise been well, they've had a fracture. A large number, I think it was like 3 out of 4, I think, Herman, in your study, that self-identified as saying, well, I've tried it. I've tried cannabis for a variety of reasons. And we make the assumption that it's for pain. But quite frankly, it seems like it's a lot of sleep disturbance. There's a lot of anxiety that happens. There's a lot of pain. There seems to be a lot of reasons why individuals are using cannabis. And I wonder, whether Harsha or Sunil, you can speak to this in your population. When people say they get relief, what are the reasons that they're actually suggesting? And I know we're focusing on pain right now, but there are other issues that are often associated with pain, which is lack of sleep and anxiety and all the other things. Is there some sort of grander effect when you're using these sort of medications or
I think it's a very, very appropriate, especially for the cannabis perspective, because pain and the other things go hand in hand. Loss of sleep, loss of appetite, anxiety, depression, loss of work. Now you got to break it somewhere. And for some, even if the pain doesn't break the cycle, something else can break the cycle. I think that is where I find, even if the indication that they would take is for, say, improving their appetite, improving their sleep, we know that improving sleep can actually improve pain. So I would tend to support a patient. I think there's one more aspect we tend to probably not consider in this is the patient perspectives. And more we go for personalized medicine, we've got to accept that evidence is not alone. We've got to look at patient beliefs, patient perceptions. As more and more people, especially young people, open up, maybe it's an opportunity to engage them and slowly take on that role. So there is more engagement, and they find even if it benefits one aspect of their chronic pain suffering, not just pain itself, that makes a huge impact on their life. Because we kind of assess pain in terms of 0 to 10, how much is the pain come down? Well, that's only one aspect of it. The suffering is from also the loss of sleep, which I think is important.
I would agree exactly with everything Harsha just said. If one looks at the biopsychosocial model of pain, there is physical pain, there's emotional and mental pain. Sleep disturbance and physical pain, in my mind, are directly linked. 2 dots, they're linked. And so that if it helps with sleep, that's great. If for people who have mental health or emotional or anxiety or depression issues and stuff like that, and if this helps them, and if their perceptions that their pain is better, leads to better physical function and sleeping and all such things, the construct, the multidimensional construct of pain is improving, however that is there. I think it would be incredibly difficult in the next generation or so to tease out the little contributors of how much does sleep disturbance contribute to an overall global perception of pain, mental and emotional. These are very, very tough questions. And if cannabis somehow is a cure for a mechanism that has not yet been understood or resolved, so be it, or a treatment for such, right?
Just with the sort of discussion around personal medicine, though, what do you guys think about the side effects or the trepidation around potential side effects? Especially say we're discussing this with people who've already been, familiar with it from recreational history, and now they've made a choice in the past that they've accepted some of the side effects, and now we're discussing it as a medication. Do you think there's, have you seen that there's less patients asking about the side effects in your clinics now just because they're already familiar with it and not really concerned, or what do you think about that?
I think ethically, whenever you introduce a medicine, even potentially harmful, it becomes our responsibility. And absolutely, you brought out that nicely in your presentation. There are definitely harms that we cannot overlook, especially, for example, in a young patient, you want to take him, definitely warn him about driving. But I think where it doesn't equate to opioid related harms is that in terms of how much baggage they carry long term is not as bad. And the addiction perspective as well, we still are trying to understand how much physiologically it harms a body or pathologically over time. It doesn't look like it's a big thing with cannabis, again, as compared to opioids. So we are somewhat safer there. But I think with everybody, there must be some aspect of education teaching that, okay, there are definitely harms. It doesn't come with no harms. So you got to be careful about this. Keep it harm in a way from your children, kids who can misuse it, because that's, again, we've ignored opioids, and half of the opioid deaths happen because social diversion happens. We got to also, clamp on that for cannabis.
I would agree with that. To answer your question kind of two ways, Herman. So if a patient reveals to us that they are using cannabis products and they are finding benefits from such when we have our appointments with them, certainly I think the onus is on us to talk about the potential risks and harms. They've probably figured out the benefits for themselves because they've been doing it for some period of time. Now, a cannabis naive patient who is asking about this for the first time, then this is a discussion like Harsha said about any medication. There are pros and cons. It's up to us to give full information so the patients can make an informed consent decision. I would love to see enough research one day to be able to construct formal shared decision-making tools where we can sit with them with a little graphic and say, here are your percentage chances or your odds of getting this and that. I think we're a ways away from that. But I mean, that's a goal. But our goal is to inform and make sure that the patient can make an informed consent decision, I think.
Well, let me ask you this. I mean, this happens a lot in areas where, the evidence is evolving, and also where there's a political reason pro and against people. There's just strong believers for and against a particular treatment. Yep. And we're seeing that right now in COVID, left, right, and center, as you can see, right? But when we apply it, let's say, to cannabis, how do you reconcile, as as physicians who are using it and seeing patients come to you suggesting that, yes, I think this is helping me, and you're becoming more and more, I won't use the word convinced, let's say, but you're definitely more favorable now than you have been.
Receptive.
More receptive. I'll use that term. Yeah. And I'm not putting words in your mouth either,
no.
Harsha, but let's say that argument. Mm-hmm. But then major guidelines come out from epidemiologists, well-respected institutions. I'll say like McMaster, for example, is one, respected institution where when they apply the strongest evidence and the most rigorous approaches, the evidence almost nearly always in these smaller trials falls short of what we would like to see as being compelling. And then they come out and say, well, listen, it doesn't meet the clinically important thresholds for a minimal clinically important difference, et cetera, et cetera. How do you then at that point reconcile that? When you look at that, do you just say, well, guidelines are guidelines, but I'm on the front line? Or how do they actually play into your day-to-day use, if they do?
Very, very appropriate question. I think just stepping back, if we look at larger amount of evidence, we all know, the herbals and this and whatnot, but we also know so many patients use it for so many different reasons. Now, whatever the science might say, I think we miss the patient perspectives. And I value a great, especially with the chronic pain population for that, because they've not found anything that works. So literally throwing evidence at them saying, oh, this is of not quality, this is of not quality, doesn't really, digest to them. They really want answers. Even if something works, even if it's not worked in 100 patients, can it work in me is their question. So to me, as a chronic pain physician, also as a researcher, I think I throw my researcher hat out and say, you know what, I want you to be better off. So if it is safe, you want to try it for a month. I'm going to support you. If it doesn't work, I think we've got to come back to the discussion table and say, is there any gain that you're gaining by using it? So I think that's where I try. I mean, we call it N of one trial, maybe if it's blinded, but I think it's worth doing that way as an approach in a patient. We're trying to reconcile the larger evidence, which doesn't match purely because you've not done good studies. That may be the case.
I agree again with everything Harsha said. I mean, when the rubber hits the road for evidence-based medicine at the bedside with the next patient, question, does the evidence that's out there generalize to my patient? If it doesn't, it informs, but it doesn't guide or dictate the care. Patient values and preferences, critical issue to ask about, right? I mean, it's not on us to determine paternalistically what's in the patient's choice box, short of keeping them safe. I mean, obviously, if there's a recommendation that a cannabinoid product is not safe to a patient because they have absolute contraindications, then that's a given. And we just have to put that out there and say, I cannot in good faith prescribe these issues or recommend them to you. What you choose to do yourself is on you, but I cannot recommend that. But everything short of that, Harsha, I don't know if you'll agree with this or not. Most of the items in the toolbox for treating chronic pain, so medications, injection, perhaps some surgical interventions, mental and cognitive behavioral strategies, physical therapies, and all such things, both passive and active, they're all imperfect solutions that perhaps contribute a mild to moderate amount of improvement. So what I tell my patients is we're trying to string a bunch of these little bits of benefits so that you can get a lot of a bit of benefit, or whatever works for you. Yeah. Right? Because it's a patient-oriented outcome is what do you want to do? And we tell our patients for sure, do not expect pain-free. We're going for pain functional. Pain-free is an unrealistic expectation, I think, at least in most of our population. But if we can offer or suggest a bunch of little things that could help a little bit, or some that help more, like physical therapies, activity-based therapy, than passive, and a non-medical strategy or a more cognitive strategy, whatever the evidence might show, and quite frankly, whatever the patients can access, afford, or have coverage for, then the more the better. I don't know if other thoughts.
And no, I just want to add that that's the same analogy we employ. We see patients with our psychologist, everybody. That's what exactly I say. Have a big blanket and put in everything that you feel like can help you, including cannabis, including whatnot you feel, it can help. And we will help you tease out which has the better chance, and then we will take it from there. And let's throw out things that don't work, and let's throw out things that are not safe for you. And then I think that's the right approach. Cannabis definitely, to my understanding, should be in that box, at least as a consideration, and then throw out if it's unsafe or if it's not useful.
There is a generational stigma that I think is starting to break down. Interestingly, more and more of our elderly patients are actually starting to ask more and more about CBD oil products, it's been a fascinating thing to watch the last year or two, because they all have a friend who tried it because their kid gave it to them or their grandkid gave them some. Generally, it's a CBD product. I'm not a big proponent of giving THC products to the elderly. Topicals, very popular, mixed in coconut oil or some base, and that they seem to be very open. They're open and receptive to a conversation where 5 years ago, probably anybody over 65 or 70, that might have been a non-starter. And that may be just a generational stigma thing that's becoming destigmatized.
That's very good. And, I want to end with a broader question, but I want to make sure if anyone else has a question or a comment you'd like to make, happy to entertain that. But without that in mind, maybe I will just ask, and Herman, a broad question that comes up always is, well, when all things considered, and maybe there isn't a typical patient, and maybe the whole thing isn't about a typical, it's probably something that's more unique, but in your practices, who is this individual that in which you would say, I think we should give it a try? Like, who is this patient? What is the typical patient you believe would be a reasonable candidate to try cannabis, given the fact that we've already discussed the evidence, and we're not 100% sure that the evidence would support all the different therapeutic improvements in pain, sleep, and anxiety. But that being said,
well, coming at it from a slightly different angle, the majority of my patients as a orthopedic trauma physician come in acutely right after the fracture, right as they're having surgery, and then they eventually do become long-term chronic patients. But then my journey with most of my patients starts acutely within the first few weeks or days of their injury. I find acutely within the first 2-week period of an injury or surgery, they need something that is going to really take care of their pain that's very real. So that does tend to still be an opiate in the majority of heavy orthopedic surgery. Once they get beyond a 2-week window and they're still having issues with pain control, that's when I brought about the discussion about a more multi-dimensional approach, including the anti-inflammatories, including appropriate use of around-the-clock Tylenol, including that's when I usually bring in the cannabis into the discussion. If they're patients that, we have a social history, know their smoking history, know their potential recreational use, and if I've seen they've used cannabis in the past, especially, I bring that up as part of the discussion. And then that's usually the acute discussion, and the chronic situation where patients are coming back to me, a year or further out from their injury, and they're having issues with chronic pain around a pelvic fracture or back injury. That's when I reapproach the discussion, much like Harsha and Sunil outlined, around it's part of the armamentarium, not a single solution, but part of the multidisciplinary, multifactorial approach.
Great. Is there anyone else want to add anything to that?
Yeah, I think one other factor that comes into is where patients just want that ledge. They know that nothing is going to work in this world, but they want this some small thing. And what happens is with cannabis, even if it doesn't kill it, they know that it takes the edge out of it. There are some patients who find nothing. Like just before this meeting, I prescribed a lady who was trying to conceive, never wanted an injection, never wanted. She had a very, even now she's on TID dose of cannabis. Nothing worked for her. 35 years old, very young. I'm still surprised as to how just the cannabis she managed through her pregnancy. She had huge CRPS, bilateral lower limb. So there are some patients who know that nothing has worked. The little bit that can make a big difference. The other spectrum, which probably doesn't do well, is they have severe pain, as Herman was saying, and trying to introduce cannabis may not go anywhere, sorry.
Just on, in terms of the functional discussion, I kind of find the patients who've used it, they discuss how, and especially after a lot of these fractures that we see, they're expecting pain. It's unrealistic to imagine 6 weeks after a femur fracture that you're going to walk with no pain. But the patients who discuss using cannabis, they tend to relate that they can just get through their physio easier, or they can still be functional through the pain.
You guys would know this better than I. I think the two of the orthopedic fellows, and Harsha, of course, I know you probably do some post-operative pain. I think there's a fantastic opportunity here to be looking at post-operative or post-acute pain control and reducing sensitization phenomenon so that they don't slide into chronicity. And I think there's a black box here that might be really fascinating to fill.
So we are actually embarking on some interesting studies in the same regard, like several in the pipeline, which Mo is also part of. And yeah, we're going to roll this out soon, probably in the next few months to a year.
Okay, so that's complete coincidence. That was not a planted question. Okay.
Let me ask this. I mean, like we're a little bit over, but I want to end with this question, and anyone can take it, or all of you can take it. When people come to you, whether it's other physicians or colleagues, I'll speak to them first, because I think there's groups who support and groups who are just anti. What's the biggest misperception around cannabis that you continually have to debunk? And it could be a colleague or a patient. I'm just curious what that is for you. What's the thing you have to keep saying?
I'd say from my point of view, it might actually be the colleagues right now that are harder to open their minds a little bit. That I think they're more locked in the stigma role. And it may be, to be fair to them, it may be also because of the lack of guidance and evidence out there to support them saying to their patients, this is okay, and we can talk about this. And again, there's lack of education and awareness and all such things. I mean, it's a 5-year-old, maybe 10-year-old story at best. So there's an inertia of information and practice change, willingness, and then knowledge to change that. But the patients, on the other hand, I think have far more rapidly embraced these opportunities. I would say the patients more so than the colleagues, but that's just my perception locally.
Yeah, very good.
I would just say just bringing it up as a reasonable option, and just I guess summarize what Sunil just said. Just bringing it into the discussion is the challenge, and that's the challenge of the colleagues versus the patients willing to bring it up themselves.
If I can add one more thing about the patients, one thing that when we talk about our pain management strategies, at least with medications orally, in our clinic with our consultations, is we do our best to actually normalize it. Make said this is yet another choice. Anti-inflammatories and neuropathic agents, opioids, cannabinoids. We don't treat it like a special taboo project. We just say it's right there. It's a choice. We go through the pros and cons of all. We match it to the patient's pain mechanism best we can elicit that, and to make sure that we have a mechanistic approach to the pain. And if cannabinoids are appropriate, we'll offer it.
Yeah, very good. Very good.
Harsha, I
Excellent.
don't know if you have another thought on how you guys do that in your clinic.
Yeah,
I'd be curious.
Just one thing to add is I think that maybe I can break it down to three different things. One, as Sunil just said, bring it up in the initial discussion, or I think my approach is probably not bring it up in the initial discussion, not because I don't treat it like medicine, but I think I put forth the one that I have definitely good evidence, which I know would be better, because patients are not aware of that. They're probably aware of cannabis, which they come out if they're really keen on it. So I want to bring them to what evidence I have. And then as a second line, I put this out. Probably there's an extreme where they think this is not even a medication and I don't want to even bring it up unless patient forces me to do it. And then I say, I can't prescribe it, go to someone else. So there are three kind of different perspectives.
That's great. Well, listen, I realize we're a few minutes over, so I do want to make sure we're respectful of people's evenings. I want to thank you all. Thank you, Herman, Sunil, Harsha, for joining us on a wonderful, tight debate on this issue, and we'll hopefully have more to chat about in the near future. Thank you all who attended, and like I said, for those of you who are interested in doing more, you can see the OE World Tour and join us for other events.